Okay, welcome everyone to this very exciting and quite possibly life-changing session. And I say this because I know firsthand how powerful a preemptive transplant panel or session on this topic can be. Um, I experienced life-changing modalities and goals and a path for myself after sitting in on a PKD conference back in 2008 on this very topic. And really, that's what is making me so excited about moderating. I thank the PKD Foundation for asking me to moderate our panel and to be a part of this program. And I truly believe that those of you that have signed up that are listening now or listening to a recorded version of this session will feel that this was one of the best investments they made in their future. I'm living my best and longest life, and I wouldn't be sitting before you stating that I'm living a great life had I not attended that session. I wouldn't have been able to bypass dialysis. I wouldn't have figured out how to find a living kidney donor. I wouldn't have been inspired to advocate for myself and to secure a better and longer life. And so I want to give a shout out before we get started to the PKD Foundation because they bring such incredible content to their constituents, myself and others. And just because my life was changed doesn't mean it needs to stop there. I truly believe that many of you will feel the impact of this course as well. I'd be remiss if I also didn't thank the mentors that I spoke to along the way. Also my donor, of course, my living donor. It took 6 to find, the perfect one. And also the experts at my transplant center. Oh my goodness. And speaking of experts, let's introduce our panel to you. First up, we have a highly respected transplant surgeon from Mayo Clinic, Rochester. He's also the surgical director of kidney and pancreas, of the kidney and pancreas transplant program. Welcome to the program, Dr. Dean. We thank you for joining us today. Could you briefly tell our audience a bit about you and some of the focus that Mayo Clinic has on preemptive transplantation?
Sure, and it's a pleasure to be here. Thanks very much, Risa. I've been talking to this group for, I don't know, or this convention for 7 or 8 years now, and it's a pleasure to do so. I think you'll get the message through this session, but just in general, don't believe anybody that tells you you need to be on dialysis before you have a kidney transplant. That's what we hope to convey today. And then I think you'll understand through the rest of the session, how to go about advocating for yourself and who to talk to, who not to talk to, those sorts of things. So again, pleasure to be here.
Thank you so much. And next up, we have a highly respected transplant nephrologist from the University of Nebraska Medical Center. I'm a big fan. Welcome to the program, Dr. Miles. I'm a big fan because I've seen him speak before, and he speaks right in tune to preemptive transplantation. Dr. Miles, can you briefly tell the audience a bit about yourself and what you're doing over at UNMC?
Yeah, sure. Thanks, Risa, for the introduction. And I too would thank the PKD Foundation for the invitation to be here, but also for all they do in terms of patient advocacy. So living donation in general is really important for patients with failing kidneys. And I think that our program tries in a variety of ways, and we keep trying to be more creative about how to get the message about living donation out into the community. And in particular, trying to promote referral to nephrology practices, but also then to transplant centers in a timely fashion. And then hopefully one of the things that will come out of a session like we're having today is what does timely really mean? Because there are some delays and in things, necessary steps to getting through a transplant evaluation have to be taken into consideration when you're going through the process. So we've tried to engage with the regional nephrology practices, but we're always looking for better avenues into patient advocacy groups, but also primary care clinics and other venues to try to spread this message.
Outstanding. And you couldn't have said it better. Timing is everything. And to complete our team, our panel, we have a living donor nurse coordinator from the University of California, San Francisco. And I will say, Helen, I caught your session yesterday. Maybe some of our attendees did as well. It was outstanding. Thank you for that.
Thank goodness.
Yeah. So, yeah, please briefly tell us a bit about what you're doing at UCSF and about yourself. I know the audience would love to know more.
Thank you. Yes, I am a nurse at UCSF, and I am a living donor facilitator. And we created this position really to try and engage our patients from the time that they're referred and really hit home as the importance of living donation. And definitely, if we can do a preemptive transplant, that is absolutely our goal. So we do. I talk to a lot of our recipients. All of our recipients hear about living donation throughout their evaluation process. We also have what we call a living donor champion program. And we recently, because of COVID, of course, didn't do it in person. We did a webinar, which was really pretty, think about this. We're doing webinars and now we have it recorded. So now anyone can look at it anytime. Nice. So we're pretty excited, and definitely, we encourage everyone to talk to everybody about needing a kidney transplant. And thanks for the invitation to be with this esteemed group.
Yes, yes. And education is key too. So timing, education, there's so much to learn in this space. And I think we all can agree that preemptive transplantation offers superior outcomes, yet we see it severely underutilized. And I think we could all agree in part that's due to a lack of education, early education, patients understanding that they don't have to start, as Dr. Dean said, you don't have to have dialysis first. Sometimes that can get a little confusing if you look at there's been an initiative for years called fistula first. And so in our brain, and it seems like a lot of the conversations that's happening in the sacred walls of our exam rooms is vein mapping, dialysis. We hear a lot of people are in dialysis, and sometimes we think, well, maybe that's just the easier route to go, just get hooked up. I surely thought that when I didn't know anymore, when I didn't know any better. And while maybe it could be easier to get hooked up, it's surely not an easier life to live. And so we do want to make sure that we are eliminating the confusion and kind of bridging the gap between that lack of knowledge and understanding. So patients want to know, curious minds, inquiring minds want to know. They want to know more like, hey, why am I not hearing this in my nephrology practice? Why am I hearing this for the first time at a PKD conference? Or why am I being able to take a deeper dive and see that as a blessing and take it and run? The questions that I think many individuals, our constituents, patients are wanting to know more about are, what's the evaluation process like, and when can I enter it? And why is it that when I bring it up, I'm kind of getting pushback like, oh, no, you're too early. It's too early to talk about that. And what does my GFR have to be? And why is it that I can contact one center and they're saying, well, we'll start talking to you at this level of GFR, where another one may have a different protocol? And does their doctor have to refer them? Can they self-refer? These are things just like, additionally, the living donor situation. Do I have to have a donor before I even knock on the door of the transplant center? And if I have more than one donor, can more than one donor be tested at the same time? So let's start with you, Dr. Miles, if you don't mind. Can you address some of these questions? You're so good at demystifying some of these really confusing areas. And if you wouldn't mind taking over right now and just kind of giving us a feel for what you're doing at your transplant center.
Yeah, sure. So, I mean, as a nephrologist, and I still see some patients on dialysis, and I still see some patients in CKD clinic, as well as devoting most of my practice time to transplantation. I think that one thing I would start with is acknowledging that it's really a complex situation. So you have a serious health problem that is going to be progressive, and you're going to have to face a series of decisions and try to navigate through that. And hopefully with the help of people around you, I want to believe that primary care providers and nephrology practices are advocating for people's best interests. But I think one of my points that I would leave people with coming out of a session like today is, don't always just assume that everybody around you knows all the answers and knows the right path. Because it is important to be thinking about dialysis, because it may be a reality, and it is something that obviously lots of patients will undergo either before a transplant or possibly as their destination therapy. I do think that practices are remiss in that they tend to get tunnel vision about dialysis preparation. And I echo what Risa said about remembering that there is also a lot of reasons to be thinking about transplantation early, in particular with a disease like polycystic kidney. So unfortunately, we really don't have a cure for this. So that at the time of diagnosis, I think it's likely that people will need to be thinking about these decisions at some point in the future. So if you get back to like, when should you be referred, that is a complicated question, because it brings into a lot of different parts of the disease and parts of people's lives. Generally, I think GFRs in the 20s are probably very reasonable. It takes a while to go through the transplant process, but also, I mean, I think we shouldn't forget that people need to be sort of wrapping their brain around this lifestyle change, because, you know, being transplanted is a lifestyle change, just like starting dialysis would be. Whether people need to have a donor ahead of time or not, I think may differ a little bit, transplant center to transplant center. But I think that patients should begin to have conversations. You know, you probably are aware of initiatives like the Big Ask, Big Give from NKF, that type of thing. Those conversations could be started, you know, way upstream of you know, getting a GFR of some magical number like 20 or something like that. So at least the people around you, whether they're family, friends, coworkers, have the concept in mind, so they too have an opportunity to think through what it's going to mean to be evaluated as a kidney donor, what it might mean to donate a kidney, because that's a big decision for them also. Why don't I let one of the other panelists?
Yeah, we'll hand the baton over to Dr. Dean, and tell us a bit of how Mayo Clinic may either differ or, in addition to what was already addressed, what you might have to add to the conversation.
Oh, I think we would agree with what Cliff said. I mean, it's not a cure. It's a different disease, really. It's not called that very often, but it kind of is. It's definitely a condition, being a transplant patient. I think, you know, you don't need to be worried about being evaluated or talking to transplant centers when your GFR is 40, but certainly in the 20s is probably a good idea. Whether or not I think it's unusual actually for folks to come to us with a list of people who are interested in donating a kidney to them. It's nice that people can, and people also have to remember that those are always just potential kidney donors.
Right.
In fact, every kidney donor is potential until somebody's sewing a kidney in.
That's true.
Because donors can choose not to do this at any time. So I think it's great to get your story out earlier. And again, people with PKD, it's rarely an emergency that they're diagnosed with chronic kidney disease or even normal kidney function and underlying PKD. So you do have, I mean, many folks have years to think about this. It's probably not the only thing they're thinking about when they're 30 or 40. But I do think, people's probably in the back of their head, their siblings may be either thinking, well, do I have PKD, or am I going to need to be am I going to be allowed to be a kidney donor? So I think it shouldn't be a surprise to most folks with PKD. The thought about, every program probably handles a little differently in regards to how many people you evaluate at the same time for donors. Many programs, and partly it's due to insurance issues, is the recipient candidate usually needs to be approved before you start working up kidney donors. And that's just often the way it is. And it's rare to work up, say, 5 or 6 at a time. most of the time it's probably more efficient to, you might screen, and I guess the definition of workup is, how far do you get along that? But certainly you can screen quite a few potential donors, whether it's via phone or via web systems, depending on which center you're looking at. But the number of donors that are going to come to the center, get all the tests, have a CT scan, et cetera, is probably going to be more like one at a time. But that can generally be done. I mean, a donor evaluation, once they're at a center, is usually only a few days, because they don't need quite as many tests as many recipients do. So, but yeah, I think, to echo what Cliff said, the more you're thinking about this, the more likely you are to have a potential donor, right? People need to know your story and need to know that you need one.
Absolutely. People need to know our story, and we have to have the courage to share it. And that kind of gives me license to shoot down to Helen now and talk about UCSF and 400 Parnassus. The reason I mentioned the address, Helen, is I was first diagnosed in 1977 at 400 Parnassus. And that's in the days that we were using contrast. And, it's sort of bittersweet. I wanted to know, as Dr. Dean was saying, it's not really a surprise. Well, of course, it was my hope. And I really didn't know so much about the genetics. So I was hoping unfortunately, my father passed in his early 40s. My brother was on dialysis and has been on dialysis in between 2 transplants. His second one is still doing very well. But I was hoping that I'd be the odd and lucky one out, and I still feel like I'm the lucky one because I was able to secure a preemptive transplant. But as Dr. Dean and Dr. Miles said, it's because I started early. I was also very fortunate at Mayo Clinic in Phoenix to start my evaluation at 25 GFR. So that gave me a head start because it took me 2 years to find an ideal donor, which was already mentioned. Everybody has potential until you're actually sewing it in. So Helen, tell me, at UCSF at 400 Parnassus, is there anything that you might want to add to the conversation about just the assessment, the evaluation, or maybe even any hurdles that some of the living donors experience that surprise recipients?
Absolutely. And to echo what both Patrick and Cliff are saying, is like, you have to talk about it. You have to talk about it early. You have to talk about it often, because it's really unusual if you discussed your need for a kidney transplant and someone said, oh, choose me, ran through all of the testing and magically, so it is a process. And like you said, you had 6 people evaluated. I think that's the challenge sometimes, is people come in and they have one potential donor and they put all of their eggs in that basket. And I highly encourage people, let all of your friends, all of your family, for us, our championship program is all about having someone else other than you do the talking. Because I can only imagine if I have PKD, I need a kidney transplant. I don't want to be the one who's the face of that. I want my friends and my family. And so a lot of times, for those 5 other people that couldn't donate to you, that was 5 other champions for you getting the word out. And so I am always telling people, if they can't donate, they're now the champion. They're now the person to be able to talk to everyone about this, because, there's a lot of myths out there. There's a lot of concern. And so the more you talk about it, the more you normalize being a kidney donor, eventually that will, be a wonderful thing. One of my favorite patients came in and he had donated 25 years before to his mother-in-law. And now his wife needed a kidney transplant. And it was just, and so talk about a great advocate, that here's this person 25 years later, and he's like, oh, do you want to see my scar? And I said, no, thank you, I'm good. So I think talking early, talking often, getting the information out. And like we've said, we can test a number of people. And again, it depends really on your insurance as to how much can we do. So we have a screening process, then we have an evaluation process, and it does kind of, smooth things out so that we're testing as many people as possible, and making sure that everybody understands what's going on.
You know, Helen, you're reminding me of, I talk to a lot of, do a lot of mentoring for, by the way, speaking of mentoring, if you aren't hooked up with the PKD Foundation's peer mentoring program, please contact them, get online. And Nicole, if you would like to put a link in the chat, that would be awesome. I mean, there are people that have walked a mile and crossed the finish line and can relay their experiences of how they got there and what their challenges were and what they know now, what they wish they knew back then, that you can glean some of those insights. But I'm reminded as we're listening to you, Helen, about some of the frustration that these mentees have shared with me and audience participants and some of my book fans and so forth that'll say, gosh, Risa, why is it that I'm just so frustrated? Why is a transplant center not telling me about my donor that's in there right now? So could you perhaps speak to how the recipient coordinators cannot really talk about the donor department and so forth? It would be great.
Absolutely. It is probably one of the, not knowing. I always tell my patients, like, I can't imagine not knowing what's going on. Not that I'm a busybody, but if it's my healthcare, I want to know what's going on. Unfortunately, because of healthcare privacy, I can't tell the recipient anything about the donor, and I can't tell the donor anything about the recipient. Now, I always remind them, they can talk to each other. So they can tell each other anything that they want, but we as healthcare professionals cannot share anything with them. We can't share with them where they are in the testing process, why they couldn't donate, all of those things. That's all healthcare privacy, but certainly you can tell each other. We just can't share that information with you.
Yeah, important to know because it can be quite frustrating. And those that are having a hard time sharing their story, I'm sure you'd agree, Helen, in addition to what you said, make sure your champions, your advocates, the team of individuals that are your spokesperson are getting the word out for you, but it might be easier for them to kind of lean into those potential donors, maybe send a group email every now and then, hey, please let us know what's going on, because the center is not allowed to pull back that curtain. And we'd surely love to know if there are any updates that we should be aware of, because that's kind of a difficult situation. But Helen, since you've got the floor right now, can you tell us a little bit more about your program and how you're taking waitlisted individuals through your donor champion program? We'd love to hear more.
Absolutely. So at our center, patients, we now have a new program where they can self-refer. And I think that, GFR 25 is kind of a magic number. Again, we can start, but then it's like, at what point, will you be transplanted? That's going to be up to your nephrologist. For us, we, from the very beginning, talk to our recipients about the need for a living donor. Our wait time in California is very long. And so it is really important that, you need to get this information out there. You need to talk to people. And so we discuss with them. Before the pandemic and when we were doing in-person visits, I would go and meet with every one of our recipients during their evaluation. Now I call them on the phone. So it's not the same thing, but certainly, we are there. And as I said, we have that education program that we put on. And, the plan is we're going to repeat that so that we're always getting out there. I personally want to send a message to all of our recipients and say, have you talked to your donors lately? And that will get hopefully the conversation going that, do you have a donor? Because, I can't imagine having to wait the amount of time that you have to wait for a deceased donor kidney.
And being that there is different wait times at different centers, but we'll look to California being probably significantly long. Maybe the coasts can be compared there, but being that there is a long wait, if they are not fortunate enough to find a living kidney donor and they are depending on a deceased donor, and I should ask all three of you, is the center repeating tests annually? And why don't I start with Dr. Dean? Do you know if a person's on the list and they're waiting and maybe 3-4 years out, they most likely need to repeat evaluation?
Yeah, and it depends on the candidate's level of health, I would say. If you're 50 years old with polycystic disease, on our list and really otherwise quite healthy, which many folks are. Another example might be IgA nephropathy or some of the primary kidney diseases. We often don't have them come back to the center necessarily. We'll get in touch with them and make sure nothing significantly has changed.
Excellent.
That's a different story than if you're 65 with, diabetes, heart disease, you've had a stroke, et cetera. So, and some of those folks we might even bring back every 6 months. So, but in general, you will on a waiting list have some sort of contact with your center in some sort of periodic fashion, just to make sure that, and it is important for folks to let us know if something has changed.
Right.
We've called people in for transplant and they had an amputation a week ago of their foot or something. So, or they were in the hospital or they're in the hospital when we call them. So the communication goes both ways, I think. Very important, if you do have a significant change in one's health, to let your transplant center know, just so they can respond appropriately.
And all the more reason to keep ourselves healthy. No matter if you're waiting for a living donor or the 4th potential living donor or 7th potential living kidney donor, we need to keep ourselves healthy. I know that in general, as you all have mentioned, the PKD community and our patient population do very well with transplant, and we have less comorbidities, especially if we're not on dialysis. But I know, Dr. Miles, if I switch back over to you, I know that you were talking about some interesting rates of deceased donor preemptive transplants. And so I don't know if you have something to add to Dr. Dean, as well as maybe brag a bit about how you've got some preemptive happenings with even deceased donation.
Yeah, I would add a couple of points to the conversation. So with respect to what Helen said about several donors sometimes needing to go through an evaluation, when we looked at our own center's experience with that over a course of about a decade, the average number of donors that was evaluated for someone who eventually underwent a living donor transplant was 8, which I think blows people's minds, because there's all kinds of reasons why someone who contacts a center thinking they're going to be a living kidney donor ends up not donating. The best reason would be because someone else was a living donor for that individual, and that was included in the number. But there's a lot of other reasons why people, and so to Helen's point, is your GFR is drifting down, it's probably not a good strategy to just put all your proverbial eggs in one potential donor as being sure that that's going to work out. Coupled to that is then the deceased donor issue, because if there is only realistically 1 or 2 people that could donate to you, you have to know that they may not be able to, or they may not eventually donate. And so while I do think deceased donation generally should be plan B, it still should be the plan ahead of dialysis if possible. The waiting times in this country are a real problem. There just aren't enough donated kidneys for the number of people who need kidney transplants. That's not likely to go away anytime soon, unfortunately. There's obviously a lot of work being done in the area of organ procurement and deceased donation, and really important work, but such a huge mountain to climb. So everybody should know that you can begin to accumulate waiting time when your GFR touches 20, but you have to be registered with a transplant center. So it differs from dialysis time. If you've been on dialysis for a year and then go on the waiting list, you get credit for that year. But if your GFR has been under 20 for a year and then you get listed, you start that day. So you sort of lost an entire year. So it is true that in parts of the country, California in particular, the waiting times are so long that I think nephrologists, probably patients, just kind of say, well, if I don't have a living donor, what's the point? And there are other parts of the country where deceased donor preemptive transplantation is a real thing. I had one of my staff help look this up, probably because I'm lazy, but 14% of our deceased donor transplants are done in people who have not yet started dialysis.
It's amazing.
Nationally, it's about 4 or 5%, which is still 1 in 20. So it can happen, but it can only happen if people get referred early. So I think in the end, what we really hope to have patients do is be looking for a living donor or several potential living donor candidates, but to be getting in and getting evaluated, hopefully getting on the waiting list in time for them to take full advantage of this policy, which is that you can begin to accumulate time when your GFR hits 20. Because if it doesn't work out with a living donor, preemptive deceased donor transplant still has significant advantages for people.
Outstanding. Excellent points. Thank you. Hey, Nicole, I think I'll check in with you. Do we have some questions that we should be putting on the table here for our panel?
We do have some good questions. We'll start with this one. We'll go back to insurance. Are insurance companies a barrier to preemptive transplant? So I think by starting evaluations earlier, is that a concern with your insurance company, or is it individual to different insurance companies?
Helen, you mentioned something about insurance, I thought. Am I remembering that correctly?
Yeah. I would never want to say that an insurance company is a barrier. We do check for all of our patients, obviously, some kind of insurance, whether it's Medicare, Medi-Cal, or private insurance. I don't know that, if your GFR is in the 40s, you probably haven't been referred, and we would not probably see you, would be my assumption. But, we haven't had any issues that I know of for getting donors tested as part of that process before someone's on dialysis. I don't know if the other gentlemen have had any experience with that.
I don't think that's as much of an issue as, it's not as, it has, I think oftentimes, people hit a GFR of 25 and then they often think they're going to be at 12 next month. It's not usually, especially with PKD, and Cliff is obviously more expert in this than I, but it's not a precipitous decline. It's generally more gradual unless an intercurrent illness happens. I mean, someone can always get pneumonia and then have an abrupt decline, but I think there's plenty of time usually, especially for folks with PKD. I don't think the insurance companies are barriers necessarily. It's just they have their way of doing business, and they're probably not going to pay for an evaluation when somebody's GFR is 40 because you really don't need it. To be fair, I mean, you might be at 40 for 5 more years. So I think it's really, it's a balance between, getting healthcare of all types at any given time versus when it's really needed. So I don't see it as a barrier necessarily.
And you bring up a good point about the decline in GFR being slower for those of us PKDers. I would say that those of us who've seen family members struggle or lose the battle, we somewhat panic when you get into a certain number base. So education, once again, whether it's Helen or her team partners saying, hey, let's review this, and hopefully someone at your outside nephrology practice that is sensitive to these issues of, I'll just confess for myself. I mean, many times I panicked, and just looking at my labs would make me panic, but I didn't realize that there would be a little bit of time there. Nicole, I'm going to give it back to you.
Could PKD patients be evaluated at multiple centers?
Sure.
Yeah, I would take that based on this concept of, even if you think who's going to be your living donor, to not, make the mistake of sort of planning for another eventuality where it doesn't work out. And so I think, deceased donor waiting times vary across states, regions, even center to center within some regions. And so I think for those who can, because logistically it can be challenging to go to multiple centers, but for those who can, it's going to help if you are awaiting a deceased donor transplant. Yeah,
it can. And everyone, I mean, most people in this country get healthcare fairly close to their home. And that's, there are a lot of advantages to that. But as Cliff says, if you do have the means to at least explore a couple of different centers, you don't want to go to 2 centers in the same city. For example, you wouldn't want to go to UCSF and then the one down Cal Pacific, I think it's called, right?
Right.
There's just no advantage to that. from an allocation standpoint. And even recently, I think the policy went live in late March of this year, allocation changed again. So you need to understand, and it's way more than, the time allotted for this conference to talk about kidney allocation, but it generally is, now it's actually the kidneys are allocated first within 250 miles nautical miles of the donor hospital. And so where the patient's listed, if that center's within those 250 miles, they sort of get first crack at those kidneys. And that's changed since, we see kidneys, for example, from Nebraska that we never saw because they used them all down there. But now we're starting to get some because we're about 215 nautical miles from there. So
interesting.
The geography is a little different now. And so you just have to work with your nephrologist or your transplant center to explore that. It's not quite as rigid.
Kidneys up there.
What's that?
Getting some good corn-fed kidneys.
Well, that's what we're used to, so it's good. But you guys never used to let them get out of Nebraska, but now we're able to get some of them. So, but it has changed. But there are advantages, I think, if you're, it's the old framework of OPOs and donor service areas and regions has gone away, and so just work with your team to know, for our patients in our area, like we're 75 miles southeast of Minneapolis, there may be a benefit to being listed here rather than there, because our circle extends to places like Milwaukee and Chicago where theirs doesn't. So you kind of have to look at where the centers, basically it's population based, honestly. Of course, with increasing populations come increasing people that need kidneys. So it's not always, you don't want to necessarily go to a crowded area either. But
I also find that those of us that have very enlarged PKD kidneys, we may be looking at centers that may be more open to double nephrectomies. I personally had a double nephrectomy at Mayo Phoenix back in 2010, and it was done same day as transplant. I know that's rare, but I know that when I speak to other PKD patients, they're wanting to know, hey, what center is a little more open to that? And would they be open to that before or after I get my transplant or same day as? So sometimes that comes into play, as well as where's my donor, my preferred or perhaps best looking qualifying donor located. And if they're across the country, there may be some consideration for location of another center.
So can I just make one point about absolutely multiple listing? It's really important to make sure that your insurance will cover the multiple listing, the evaluation, and thinking about the logistics afterwards. For us at UC, we see, and I'm sure you guys do too, we see patients weekly after they're transplanted. So you're going to need to be somewhere local. And so you need to think about all those things. And the other thing, we do have a long wait time, but we have great outcomes. And so that's the thing too, that I always caution our patients, that not only look at how fast, but make sure that you're going to get a great outcome. So those are just my hot buttons to make sure that our patients know about.
And some of the work done at one center can often be used at another center. If we get the echocardiogram results from UCSF or Nebraska, we'll say, okay, you had your stress test, and that's probably okay. And so just make sure the center's not repeating a lot of things necessarily. They may want to do some additional things just due to styles of practice, but a lot of it can be done. It doesn't have to all be repeated necessarily.
Right. You don't need brand new information on the same echo.
Right.
Excellent. And Nicole, I know we only have a couple minutes left.
Yes, we need more time because I've got some really good questions. So let me throw two things out that maybe we could answer. One, if someone needs a dual kidney and liver transplant, how would that impact being able to get a preemptive transplant? And then I also had a question about pain and patients pursuing preemptive transplant, kind of driven by assisting with their pain. So how does getting a transplant impact the level of pain a PKD patient is experiencing?
Whoever wants to speak.
Pain related to their native polycystic kidneys? Is that
yes.
what you think?
I believe so.
Yeah. A kidney transplant by itself doesn't help that. usually. I mean, in the short term, it causes more pain in a different part of the body. But I think as Risa mentioned, there are options to have the native kidneys removed. We've both Arizona and Rochester here, we've been pretty active in doing that at the same day. Before we started doing that, we would typically take them out at about 3 or 4 months after the transplant. We preferred not to do it before, mainly because that makes people without kidneys. And being on dialysis without kidneys is really hard, even if you're only going to do it for 6 or 8 weeks. There are many options and each center may have a different style, but I don't know that there are that many centers that are totally averse to taking out native kidneys. The question about the liver with a kidney is a bit more complicated because all of the waiting time, if you will, or organ allocation is based on the liver at that point. And so that is something and those scores for people with polycystic liver disease are what are called appealed scores. There's a standard score. If the appeal is approved by a national review board, you get an appealed MELD score, and MELD is a complicated system. And so where that score sits kind of relates to where you're going to get a transplant. But that score is not the highest MELD score. It's not the lowest either, but it's somewhere in the upper 2/3. So it may, unless you're going to pursue living donor liver transplant followed by a living donor kidney, and that gets a little logistically interesting. And people have even used the same donor, not very often, but we're going to try to do that soon, not for a polycystic patient, but for a liver patient who had her transplant yesterday. But it probably decreases the likelihood of a preemptive transplant.
Yeah.
Just given the liver waiting times. I think that and while Nicole is looking up other questions, it's not a failure on anybody's part if you don't have a living donor, you don't have a preemptive transplant. It's nobody's fault. If you've done the right things, you've gone through, you've been proactive. I don't want people to come away with it being a failure. It's certainly the preferred approach, I think, for most transplant centers and recipients probably too. But I don't want people to come away with a concept that I did something wrong or that I'm going to die, because, we do see people on dialysis for many, many years. And a year or two of dialysis is probably manageable if you had to. We transplanted a girl the other day that had been on dialysis for 24 years. Wow. Finally decided she wanted a transplant. So it's not a death sentence. I mean, you can still work, you can still be active, you can still do things. So I don't want this conference to come across as the only way to get a transplant, just so people don't, beat themselves up too much.
I think that's a very good point. Risa, I'd like to throw this out there. I know we probably have like 30 seconds left, but we do have a break after this. And
well, there you go.
Maybe we could go like a minute over or something.
Sure.
So, maybe we can't begin the evaluation until, a certain GFR. We've had several comments that I read through. And so I wondered, to Helen's point a little while ago, you said, have you talked to your donors lately, or, something to that effect? So if we can't start an evaluation to a certain point and we want to be proactive, what are things we can do to be talking about this idea of a preemptive transplant well ahead of a GFR of, 20 to 25?
Well, first of all, I want to say that I do not want anyone to think that it's easy to talk about needing a kidney transplant. So we talk as if it's like, every day. So I want to make sure that people understand that we know that's not an easy conversation to have. And I think that, you can't always, every time you talk to your friends, you can't say, don't forget. But I would want you to say and make sure that, maybe in the holiday letter, thank you so much for all of your concerns and your questions about this. Here's my update. So again, you're keeping people updated as to what's going on, and they can think about it. To Cliff's point, we want people to think about it, and you want to get started thinking about, can I be this person's donor? And that's the other thing is, you might actually have to tell people, even if you're on dialysis, you might have to tell people, I need a kidney transplant. Because I've had patients say to me, my friends know that I need it, that I'm on dialysis. How come they don't know that I need a kidney? It's like, well, you actually have to tell them. So I think that, you know, when you tell your story, you have to say, I'm on dialysis, or I'm going to start dialysis, which means I need a kidney transplant, and a living donor is my best option.
I would just add, and I think Helen mentioned this earlier, but I think having someone, and maybe it's a spouse or someone in your family who can't donate for whatever reason, they can still advocate for you. And just like sometimes it may be easier to bring it up from that angle, to say, this individual needs a kidney transplant, and I'm sort of like acting as an advocate for them.
Yeah, and especially it's, you know, if it's someone that's a close family friend or whatever, and they can't donate, now they're like, I failed them. It's like, no, actually you have another opportunity. You can do, and you can actually say, I tried, because this is the thing too, is that especially with spouses that can't donate, and they're talking about needing, you know, their loved one needs a kidney transplant. I tell them, you have to tell people, I tried and I couldn't do it because X, because that also speaks to, we're not in the transplant world, we're not going to just take everybody and anybody. You have to be in exceptional health. You have to have great kidney function. You have to be for the long term. So I think that that speaks to the safety of the thorough testing program that we all do, you know, put our living donors through.
Exactly. Well, I sure hope that this program has your ideas spinning in your head right now, and that you've generated some excitement. So, because maybe you know a little bit more about the path to preemptive transplant. We want to make transplant more believable and achievable. And to speak on behalf of the panel, I think we all agree that transplant should be a choice, not a challenge. But the only way to really take the barriers down on that challenge is to get with people that know more, like Helen and her program and other programs across the United States. There are some great books, one I even authored. There's just some great tools out there, and you may not be hearing about these in the sacred walls of your exam rooms. So, you know, please bookmark this program and go back and listen to it again, and take those notes and thoughts that you had in terms of what do I do next, and reach out to Nicole if you want to find a mentor that will help you get to the next level. Many of us are here to help and want to see you live a better and longer life. So thank you all for joining.